Welcome back to episode 3 of Shift Talk. I'm Brett. With me, someone you may know and someone who looks a little new.
Hi, it's Cody, as always, sitting in the other passenger seat here. And today we have Mr. Wallace. Please introduce yourself further.
Hey, how's everybody doing? Name's Kofi Wallace, FTEP specialist in the Eastern Division.
Today we're going to talk about fireground emergencies, and who better to talk about those things than Kofi Wallace himself. So, things we're going to kind of cover are kind of where to stage on these types of calls. Sometimes we are the first ones there. It's rare, but sometimes we do. Where to sit at the cold zone. So, like, from your perspective, as not only a firefighter, but also as someone who works on the ambulance, what was your kind of outlook on where to park? Where's the best place to park? Where might the chief try to stay? Because that's the person we're going to try to make contact with when we get on scene first. So, kind of tell us about that.
Yeah, typically you're going to get anywhere from 5 to 7 and sometimes more fire trucks responding, including a chief vehicle and some other utility vehicles that you might get responding. So where you arrive in the span of time obviously can significantly impact where you would park an ambulance. So early on, if you know where the fire structure is, you want to park far enough away that you can allow multiple large vehicles to approach and have the best access to the actual fire structure. You'll find that most fire departments have a space that they'll allot either in one of the corners of the structure or right in front for a ladder truck. And as we all know, those have the worst turning radius of all vehicles. So taking space up closer to the actual fire scene is going to be problematic. So staying an eighth or a 16th of a mile away sometimes can be the best approach, which obviously can make some more longer traverses with your cot. However, if there's a larger parking lot near the structure, if it's commercial or a residential area near commercial, that would be the best area to park. And so when we talk about a chief that's going to be commanding the scene, they oftentimes want access or view of two sides of the structure. So if you're looking at the front of a structure that's on fire, they're going to want to park somewhere in one of the corners. They label them A, B, and C, and D corners. So they're going to want to be in a corner where they have access and view to two sides of the corner. Just gives them a really good optic on crews operating on the scene.
Yeah, when they label Alpha Bravo Charlie Delta side, you'll hear that a lot in the radio comms. How do they come up with that?
So typically for most departments, it's going to be street side or address side. That's going to be your A side. And working in a clockwise fashion will be B, C, and D.
Gotcha. Yeah, that's one of the hard things is from the EMS side of things, usually the only education we get on fireground is park uphill and upwind, right? And stay out of the way.
Absolutely, and it does matter because if you park too close, you certainly run the risk of large diameter hose being filled with water behind you, which kind of locks you into the scene until the fire's under control and they disconnect those hoses. So based on if you're going to be at the scene for the duration, that certainly can play a part in your ability to actually transport patients if that's going to be one of your functions at the fire.
So, you arrive on scene. What would be the first person you'd want to try to make contact with? We talked about the chief, so you know that they're going to be labeled on a corner, whether it's your Alpha, Beta, Charlie, Delta, whatever side. But I ruined that, didn't I?
Totally, it's fine.
But, right, so you'll
All right.
find the chief's car, and then I know that from experience, they're usually the guy sitting there constantly on the radio with a clipboard, constantly doing stuff, but what's a good way to approach them?
Absolutely. So it's obviously this delicate dance. You park your ambulance and maybe you have your partner start to gather up all of the equipment that you want to take to the scene and kind of stage and be ready in case you do get a patient. You want to approach the chief's vehicle, one where he can see you and you can see him. Oftentimes it's really heavily laden with radio traffic, at least in the initial stages of the fire. So they will have a assistant, an intern, a safety officer that you can certainly talk to as well. But if you're able to get a moment of the chief's attention, you can let them know, hey, you're on scene, where you're located, and that you have switched over to their channel. Now, if you didn't get the information about what channel they're on, you can certainly ask at that time and make sure you switch at least one of your portable radios over to that fire channel so you don't miss any pivotal traffic. Now, certainly, there's no need for you to key up on the fire channel because there's a lot of pivotal information being transmitted in those early parts of the fire. And so typically they will report some traffic. Hey, have EMSA come to this location or have EMS report to this. You can simply just do that or check in with a firefighter to find out what exactly they're talking about and where they need you to respond to.
Any of my experiences in the past have always just been immediately get on scene, go talk to chief, and I usually get the, okay, cool. And then I'm like, we'll be at our truck if you need us. So do you always recommend trying to stay at your ambulance, depending on how far away you are, obviously, or do you think that standing just like hanging out right where kind of he is with your cot just waiting? Or I know trying to get over all of the different sized hoses and stuff with a cot can be a nightmare. So what would be your...
It really depends on the scene and the access. And so we talk a little bit about fire safety, and sometimes by virtue of where the chief will park, just to have a really good view and based off of the wind and the amount of smoke that's coming off of a structure, I certainly don't want to stay close to the chief if all the smoke's going to be pushing towards the chief vehicle. So a lot of times I would just let the chief know, hey, where I'm going to be, and I will make the adjustment based off of where the smoke is, and I want to stay out of the smoke, right? And sometimes you'll hear people say, hey, I want to be upwind. Well, you'll find that fire sometimes, the wind may be blowing this way 1 minute, and you go over here, and next thing you know, it's blowing right to you. So it is a very dynamic situation.
I get that at the campfire all the time. They say smoke follows beauty.
Something like that.
You know? Okay. All right.
Yeah.
All right.
So I don't know about you guys. When I show up on a fire scene, I'm looking for the white hat. That's usually the chief in charge, at least out here in Oklahoma City. Is it the same for Tulsa?
Yeah, absolutely. So our chief officers wear white helmets. However, in Tulsa, you will occasionally, if a chief is off or doing something else, we will have interns or captains that will fill in those positions for the day or for a couple shifts, and they have red helmets. And they'll have identifiers on the side, helmet tags, that will be white. And that is kind of alerting other firefighters that that firefighter is acting as a chief that day. So you'll know that that person, that firefighter, is the chief for that fire.
Gotcha. I know that.
I've never seen helmet tags before. I have no idea what you're talking about.
Yeah.
I know that they will tend to work like in any position in the fire department. You can work one space up and one space down. So like captain could go to driver and vice versa. Is that correct? Or
Yes and no.
Okay.
And so firefighters oftentimes can work up, but you will never see like a chief officer working as a captain.
got it?
Or a
Okay.
captain should not be driving the truck. One, because they haven't drove a truck in a while and you probably don't want that. So we typically will have, you can work up a rank or the rank that you are.
Got it. Okay.
And so back to the helmet tags, you've probably seen them and just maybe not recognize those as helmet tags.
Absolutely. Yeah.
So on the sides of the helmet, you'll see an E or an L, or you'll see a number, and that's typically designating the station that they're at or the truck that they're on. And so the colors, a lot of times, will signify the rank they are.
Gotcha.
All right. I did not know that at all.
Huh? The more you know.
Yeah. Right.
Now that we've totally ADHD off track, let's talk about when we have more than one unit responding. Say you get that god-awful medic.
Absolutely. Obviously, can be a very dynamic situation. Even though we have protocols for the first unit maybe being the standby unit and not transporting, we do know that when emotions are high or if a firefighter goes down, a lot of times the emotional stress of the scene probably isn't going to allow us to tell a firefighter, we're the standby unit. I got you one coming. You might get your ambulance commandeered, if you will. So to be a little bit adaptable to that certainly reigns supreme in that situation. Ideally, you would want an ambulance to kind of have an understanding of what's going on and bring another unit in, but sometimes there can be a lag for that second unit. So being adaptable to the needs of the situation, very important. So let's say we do have a unit on scene and we know that firefighters are working on bringing a patient out. We should either work with dispatch and start that second unit knowing that we're probably going to have a transport or working that medical, or we start thinking about adding a supervisor to the incident to start working it as maybe a potentially multi-unit response or a multi-patient response and start building that command structure on the EMS side.
Gotcha.
Well, it makes a lot of sense. I mean, you want to call a second unit, go ahead and get them started. What's the worst case scenario? You cancel them? Like, it's not really a big deal at that point. You bring out someone who is not workable or things like that, or maybe it's just it's going to be a refusal. But you said, like, obviously, high stress situation, a firefighter goes down. But we do also do rehab. So I've been on plenty of scenes where I've done fire rehab, and that's kind of what they called us for, was to set up rehabilitation stations and things like that. So what's kind of from a firefighter stance, what do you want to see from us, from the EMS side of how to like kind of get that stuff set up, and what exactly are you looking for?
Okay, yeah. So fire departments will have rehab trailers and rehab officers. And so typically you'll set up rehab if we know the incident is going to be prolonged. We have either really high temperatures, really low temperatures. So if we're talking about really high temperatures, we're going to bring MC units in to supplement rehab. And what that looks like is cooling, checking vitals, reporting back to the rehab officer, minimal treatments. When I talk about minimal treatments, I'm talking about dunking limbs in buckets of water to kind of bring that core temperature back to where it needs to be. If we're talking about treating, we would be bringing in additional units to kind of do that treatment. But it's really a supplemental role to provide vitals monitoring and making sure that the firefighters are staying ready to go. Typical rehab is kind of a rest and recovery. When we're talking about elevated temperatures, sometimes that involves bringing those temperatures down so we can get them back in the fight, if you will, or determine they need to stay longer, or even, unfortunately, sometimes go to the hospital to be evaluated.
Right.
Been there.
Yeah. Deluge. Have you seen that used in the fireground?
Absolutely. I've seen it. I've seen videos that I believe you all have produced. That is going to be very much a function of everybody kind of coming together, because it is, I would say, a halo event. It doesn't happen as often as you think. And so those are the skill sets that we need to practice often, so that when we need to do it, it is a little bit more seamless than everybody opening up instructions and trying to do it. But it does work really effective in bringing that core temperature down. And so coordination is really high in that. We would have to use a hydrant to kind of add that water to the actual bag.
Yeah.
So we've talked about the, fireground safety and things like that. The next big thing I kind of want to just cover slightly is the different stages of fire. We don't really get to see a whole lot of this, because 9 times out of 10, whenever we show up, it's either at, stage 2 or stage 3, or maybe even at stage 4, and we're there just for rehab purposes, depending on what kind of building it is. So I'm not going to get into that. But what is the initial stage of fire?
So we have the incipient phase, and I would say typically for this phase, the fire department doesn't see a lot unless they're driving by and they see a wisp of smoke.
Sure.
So we will typically receive our calls from third parties, passerbys, alarm systems. And so majority of when the fire department gets the call is when it goes into that growth stage. If we're lucky, if we get the call early enough, or unfortunately, sometimes when it gets to that fully involved stage where you see it coming through the roof, out the windows, and almost every compartment, and it has some stage of fire in it. and not a whole lot of livable space.
Break out the marshmallows.
Yeah. And then obviously after that, you have the decay phase, or you might have an intermediate phase where it goes out. And so the houses that are built nowadays are very insulated, and there's not a whole lot of air movement like the houses we probably grew up in. And so if it starts and all these doors are closed, it's basically going to utilize all the oxygen that's in the space. And once it gets oxygen starved, you're going to start to see the flame go down, and it will go out if we do not get an introduction of oxygen. This is why we say a lot of times close the doors when you're in your residence, because if a fire does break out, it won't get into your space or your bedroom to harm you or get some more of that oxygen that you're slumbering away with.
So if we're in that incipient stage and we haven't quite grown yet and it does snuff itself out, what kind of injuries are we looking at then?
So we're looking at smoke inhalation and asphyxiation. And so as the oxygen goes down, a lot of times you're not going to know it. And you might, if you're already asleep, you're just going to go unresponsive and ultimately into cardiac arrest if you don't have the oxygen you need. And so there is a moment in time where that patient is savable. And so we're obviously relying on the firefighters bringing them out so we can do what we do.
Gotcha.
So after that, then we move to growth, right? And that's obviously when the fire has started to not only consume more oxygen, but it's got more fuel, whether it's burning different types of materials or other things like that. So obviously this is probably where the fire department's going to get called and where they're going to start. We hope. I mean, we'd love to catch it at the very beginning, but what kind of injuries do we think we would see in a growth stage?
So in a growth stage, I would hope ultimately that it would wake somebody up and they could get out of the structure. Now, if they're not able to make it out and fire department gets on scene in the growth stage, there is a high potential to save people in that phase if they stay low. Most people are either sleeping, so they are low, so the heat does rise, and while there's still oxygen-rich environment, you're still able to breathe. But you do have that radiant heat that kind of pushes down on you, so you're going to start to see some of those thermal burns, your first degree, your second degree, and unfortunately your third degree if you have a lot of poly in the room.
Now it can hit the airway too, right? At that stage.
Absolutely. As you breathe, that air gets superheated, and you will start to get some of those airway burns. And obviously, if that happens, you can have swelling and a cardiac arrest for a different reason outside of just the burns.
You just said poly. What was that?
So just the material. And so we, growing up, had a lot of cotton furniture, and it was all non-synthetic material.
Lead paint.
Shag road.
Everything, I think, in most homes now is synthetic that burns a little bit higher. And I know in the fire department, we always refer to the furniture and the finishings that we have now essentially as gasoline. So once it gets to a certain temperature, it is only adding to the intensity of the fire, the heat of the fire, and it actually fuels the fire getting to that fully developed stage that we were talking about.
So, assume that your fire doesn't get taken care of right away. We go to fully involved. I'm sure we've all seen those types of calls where you roll up and you're like, wow. You can feel that one from the street down. You're like, this thing is hot. Obviously, I think the injuries we're going to see here are most likely going to be your high-degree burns and things like that, depending on how long you're in there, and vice versa. And obviously, we'll move into cardiac arrest and things like that with no oxygen. But what are some of the injuries that you might see in firefighters in these types of stages, like the growth and full involvement?
So for firefighters specifically, technology is such that we can be in our bunker gear, as they call it, fully encapsulated and kind of isolated from the incident. And so prolonged exposure to high heat can give you compression burns, right? And so properly fitted bunker gear, really important for firefighters. And so a really tight fitting set of bunker gear is going to probably provide what we consider compression burns. So as I put my hand on you, the heat is going to transfer to your skin a lot faster. And so the bunker gear has to be somewhat loose fitting to allow a little bit of space in between to not provide for compression burns. So typically with firefighters, at least initially, you're aside from being overheated, you'll see compression burns where the SCBA harness kind of sits on that bunker gear and the belt strap kind of comes around, or anything that's going to push the bunker gear down on the skin. You'll start to see the burns in those areas.
What types of, you say, compression burns, what would they kind of look like? Do they start out, like when you've had a sunburn, you're like, wow, that really sucked, and then it turns into like what you would call a, stage 2, or they used to call second degree back in the day.
Partial thickness.
Right?
Thank you. But like, is it something you should look at, especially when we're doing rehab? We should maybe check these areas to make sure that something's not kind of growing over time.
Yeah, so when we're talking about rehab, typically the rule is if you don't take all of your gear off, you at least pull your bunker pants down over your boots, take your coat off so you can properly allow yourself to kind of let some of that heat release. And so think of those compression burns as a reverse sunburn. You know how you wear your bikini or your swimsuit, wherever the sun hits you is where you would get burned, right? So the opposite is true with bunker gear and radiant heat. And so wherever things are touching your skin is where it would get red, or you would receive those burns, because the heat transfers a little bit more readily with the closeness or the solidness of it.
Interesting.
So think harness, think elbows if they're crawling or doing something like that, or if there's any type of direct flame impingement on their bunker gear or anything like that. Those are going to be your high potential for burns.
So then the final stage of fire is decay. And that's like you were saying earlier, like it's burned up all of its fuel, all the oxygen is practically gone. I'm sure if anyone who's ever seen the movie Backdraft was like 96, I think, you should probably have your prostate checked. So how does that happen?
So in the decay stage, the fire's out. We've kind of run out of fuel. The problem is the fire is still off gassing, and they're putting out primarily, aside from a lot of other dangerous gases, they're putting off what we refer to as the toxic twins in the fire service, and that is carbon monoxide and hydrogen cyanide. And so with carbon monoxide, of course, you're not able to kind of smell it, right? It's odorless other than the smell of burning things, which you're going to smell anywhere. And it displaces the oxygen carrying ability of your red blood cell. And so first things we'll see as paramedics or standby units is altered mentation. And so that's kind of what we're looking for. Fire departments are really strict on making sure firefighters are wearing their SCBA or their mask after the fire to avoid this. But that's typically what we would see, whether it be from patients there or firefighters working. And if it's cyanide poisoning, we obviously would use our cyano kit that is carried on the fire department vehicles to take that poison out.
So we don't carry cyano kits on the ambulance. So only the fire department carries them. Is there certain units that have them? Does every truck have one?
So not every truck has them. And so the units responding of the ones in Tulsa, the district chiefs in Tulsa will carry 2 cyano kits. The EMS supervisor or the EMS supervisor will carry 2 as well. And so here in Oklahoma City, the battalion chiefs, I believe, carry 1 cyano kit. The transport for OKC Fire supervisor carries 1, and I believe your hazmat 6 carries a cyano kit as well. So those are the units you'll kind of be looking for to get those if smoke inhalation is suspected, which will be indicated by a little bit of soot around the mouth, and they were in a closed compartment, and you have a little bit of altered mentation. Those are kind of our indications for use of cyano kits.
That's one hard thing is where do you draw the line of they've obviously inhaled some smoke, but maybe they're ANO4 and they're vitally stable. Where do you pull the trigger on that cyano kit?
So when in doubt, obviously, if it's a firefighter or a patient and we have soot around the mouth and you know that they've been in an oxygen depleted environment, you know that there's been some form of carbon monoxide poisoning or potentially cyanide. And so when in doubt, obviously, if it's available, use the cyano kit to potentially get any of that poison out, because time actually is a factor when we're talking about that.
A lot of times, a lot of the research that I've looked at too is that you'll have airway complications or things like that that may look normal now, but will change, 20 to 30 minutes down the road. So I think it's a good idea to maybe at least talk to the fire guys when you're there and be like, hey, I think we should probably look at doing this, because they're the ones who are going to probably get that set up for us.
Absolutely. And the fire department, a lot of times, really focused on the fire and getting the fire put out. And you might have an EMS supervisor on the fire side that's really thinking about that. But something we can think about is the number of patients we have and how many cyano kits would we need based on the number of patients if we do have that smoke inhalation where we do have soot around the nares or the mouth. And so I've been on fires where we've administered up to 5 cyano kits based off of the patients that we've had. So if we just have our one chief there in Tulsa, that's only 2 kits. So how do you decide which to get it? So proper forecasting can kind of help you out in making sure that you have the right amount of medication on scene for the number of patients that you potentially could have.
Right, triaging it down.
You said that Hazmat 6 here in Oklahoma City carries one. Does Hazmat get sent to every fire?
It really depends on the response, the fire, and so they will have target hazard kits that say this building or this structure has this many chemicals and might automatically trigger the hazmat to respond. Sometimes the fire department will be used to help out that rehab function, and sometimes, unfortunately, they might be on an actual hazmat call when that fire comes in. And so you can't be overly reliant on hazmat being there. If they are, it's a blessing. If not, we'll have to make the proper adjustment, whether it be an EMS supervisor or respectfully asking the battalion chief or the district chief if you could have that cyano kit and potentially one of their paramedics to help you with the administration of that.
Thankfully, we're fortunate enough that you brought up kind of a practice one that we could kind of go over. So give us a couple minutes and we'll get that set up for you.
One eternity later.
So now that we've got this set up for you, let's go over some of the steps of what you might see.
Absolutely. So when we're talking about giving the cyano kit or hydrocobalamin, you want to make sure that they fit the criteria. And so per our protocol, we want to make sure that they're suffering from smoke inhalation indicated by a little bit of soot around the nose or mouth, but I don't want to use that as an exclusionary. They were in an enclosed compartment as a patient. And so really, really important. And then we add a little bit of altered mentation. Kind of lets us know that we're displacing a little bit of that oxygen or they're suffering from cyanide poisoning. And so after you get the kit, if you do not have a fire paramedic that is able to set that up for you, want to quickly kind of just go over some of the things that you'll see so that you still would be able to administer it. Both Oklahoma City Division of IMSA or Tulsa should have some of these. So if you want to come in and look at one, shouldn't be a problem. So it will come in the box, and there's a couple different things that you're going to kind of see in the box. One is the vial of a material, and that's actually the medicine that you will have to reconstitute. Very important that you do not rip this vial out of the box. And so super important because this becomes your IV bag in essence, as you see it hanging here from a pole. And so you've got 5 grams of medicine in there that would be reconstituted with 2 100 ml bags of normal saline that will be in the box. And so other items that you'll find in the box are going to be a transfer spike that looks like this. And so that is so you can puncture into the vial and squeeze the normal saline actually into the vial. Once you're done putting 200 mLs in the vial, you can remove the transfer spike and make sure that you have a 10 drop set, preferably with the addition of a needleless port in addition to the connection. Sometimes you'll have a extension set as well. Sometimes you won't, but it just adds a little bit of versatility. Some additional things that you might see in there is a 3-way stopcock, and that allows you to draw up medicine and push it through the line, especially when we're talking about an IO that actually has been initiated on the patient. And so when we think about an IO and fluid going through marrow, a lot of times we have a pressure bag, right? Just to kind of help that medicine or that fluid get in. Well, we're not really able to get a pressure bag around our vial. And so this kind of allows us to pull the medicine out of the vial and push it, especially when we're talking about putting it into an IO. And so if you have the needleless port, that allows you to just pinch, pull the medicine up and push it. If you have a 3-way stopcock, it is simply turning it off to the patient, drawing the medicine up, switching it back, and pushing it into the medicine. So for an adult patient, we're going to give the entire 5 grams. And so if you are able to hang that up and let it gravity feed in an IV, works perfect. In an IO, you may find yourself in a situation where you actually have to draw it up and push it. And so when we're talking about pediatrics, 70 milligrams per kilogram. So if we have a 50 kilogram child, kind of a larger pediatric, we're going to go 3,500 mLs or milligrams. And so it really helps to be able to calculate how much you're actually giving when we're talking about that. And so if we've got 200 mLs in our vial there, if we were to give 3,500 of that, it breaks it down a little bit easier for you so you know exactly how much you would give it when you figure out your math versus looking at the bottle and trying to figure out if you gave enough, which could be problematic for documentation purposes.
Sure. So I've given this a couple of times, but really the big thing that when we got to the hospital was they wanted to know, like, when exactly was it started? Obviously, you're probably not going to finish it because the amount of time now, obviously, we have the Tulsa transports are a little bit shorter than your guys's in Oklahoma City. So what would be some key things you'd want to make sure to tell the hospital about these?
Absolutely. So typically we're giving this over about 15 minutes, which can kind of vary based on if you're having to pull it or push it, or if you're regulated by a drip set that is gravity only. And so we want to, tell the hospital that we did give it. And if we weren't able to give the entire amount, we would want to let them know, hey, we gave about half of it to this point. And so the key to that is this medication is primarily excreted in the urine. And so it binds to the cyanide in the blood and excretes it in the urine. And so it's basically a very large dose of B12 vitamin. And so one thing that it's going to do for your patient is if you let them know, they're going to kind of understand that the patient is going to turn kind of cherry red. And it's also going to make the urine turn red as well. And so if you didn't tell the hospital that you gave this, they're certainly going to run a lot of unusual tests and think that there's internal bleeding for the patient. So really, really important that you told them that you gave it, how much you gave, and obviously any other issues that you might have. Obviously, if there's soot around the mouth and everything else, you may have intubated or something like that. So patient's probably not going to talk for themselves. So you, again, just like any other patient, you're that patient advocate to kind of let them know everything that's been done.
Can you push any other medications while this is running? Like, you can piggyback certain meds off other meds and things like that, but this doesn't seem like it would allow that.
Yeah, so you want to keep it entirely separate once you start this medication because you obviously want to give the entire dose. you don't want to stop the dose to give something else. And so if you're doing an IO, it would behoove you to start either another IO or try to get a different IV.
Okay.
And obviously, if the patient goes into cardiac arrest, we're going to kind of transition over to that cardiac arrest model, and maybe we would come back to this. But that would be the priority at that time if the patient, unfortunately, goes into arrest while you're giving that.
And then how much of this can we put down the tube?
Including nothing, it's going to be nothing.
Okay, good. Some people are old enough to understand that reference.
Yes. Be very careful when you're mixing this up. If you're not really sure, every box also comes with an instruction card on how to mix it. However, in the chaos of a scene, a lot of times these just get thrown to the floor. And so after you do mix it up, really, really important that you take about 60 seconds to kind of reconstitute that powder that's down in there. We call it the ruby red slippers because that's exactly the color it looks like inside the bottle. If you spill this for any reason, it does look like blood on the ambulance floor. So it will make a burn look, although it is a thermal trauma, look like you bled the patient out. And so you might have people looking for some cuts or bruises or something that happened, and it really is just the medicine that's down on the floor. So be careful with it.
Protocol 16W. If anyone wanted to read that for themselves, appreciate it.
Absolutely.
So the things that we really wanted to cover for this was just kind of like what to do when you first get there, where to check in, things like that. I know we had a call recently where we had a crew that just kind of went on scene, did exactly what they normally did. They pulled up, hit the on scene button, they just kind of chilled. And then the fire department kind of needed them to go somewhere else because whether the smoke was moving, I don't remember exactly what it was, but they needed to move them and they couldn't really get a hold of them. So of course now you have to pull someone from the scene to go try to hunt down a random ambulance somewhere and then tell them to GTFO. So that's kind of some of the things we wanted to cover on exactly what we were talking about when it comes to all the fireground safety stuff. So we talked about rehab and kind of what to do. I know that, remember that you're dealing with these firefighters who this is their whole job. To get out there and fight fire, right? Everyone loves it. It's great. It's fun. Everyone's having a good time. But when their heart rate's too high and they're trying to tell you that they feel fine, talk to the EMS guy.
Absolutely.
Talk to
the rehab officer, the
rehab
EMS officer.
Yes. Talk to those people and let them kind of decide. Please don't send these people back because, they say they're good. They've got high heart rates and high temperatures and things like that because the last thing we want is to make them an actual patient whenever they run back in there and immediately collapse. I've sadly seen it, and it's just, don't listen to them.
Yeah, Cody, it's like anything else. Communication is the key. And so it's not our job to show up on scene and not tell anybody or just hit buttons. You got to kind of communicate and let people know what the situation is, what you're there to do. You might be at an apartment complex there for another medical. So even if I pulled up to a fire and I was there for another medical and the unit didn't show up, I would still at some point kind of let that chief know, hey, I know you see an ambulance over here and we're here on another medical. Your unit is en route. And so one thing I can tell you for sure is no fire is the same. You'll have different people on the fire. Like you said, you'll have firefighters that are doing different tasks and aren't overly focused on different things. And so the information we're sharing with you today is basic guidelines because you will pull some of these off the shelf because every fire is different from where you park to where you stage, even to who you check in with. What do you do if the chief is nonstop on the radio? What's your next step? Is to find another firefighter, find another high-ranking individual, let them know you're there because you might not always get that opportunity before a patient shows up to kind of let that chief know. So the information we're giving you are great tips to kind of take into a fire scene, but certainly like you were saying, you do have to communicate because you might run into those issues that you were speaking of where they kind of needed you and because you didn't communicate, they weren't able to get a hold of you, weren't able to make that connection when they needed the help.
I think that just about wraps it up for us. Did you have anything else you wanted to ask while we were here, Brett?
No, thanks for coming on, Kofi. That's really good information. Hopefully this helped you guys out when you run those fire scene calls and give you a little more confidence as to what's going on, what to look for, and how you can better do your job.
Absolutely. I appreciate it. You guys have me on anytime.
You're the first guest. I've been Cody,
I'm Brett.
Kofi.
and we'll see you on the next shift.
Thanks for your service.